Hey everyone. Hey Kyle. So we'll give people a few minutes to hop on, but glad to see everybody joining. And we'll start with introductions in a couple minutes. All right, welcome everyone. So we can get started. And as Vanessa said in the chat, feel free to introduce yourself. So people who are used to our regular MapNet calls will notice that we have a larger group today. So welcome everyone who's joining us through the MHTPC as well. So we're excited to be talking about this topic. I know there's been a lot of interest from this group and beyond. So really happy to have you all here. So we can move forward to a couple of our announcements beforehand. If Vanessa, you can go to the next slide. So just an update that participant microphones are going to be muted on entry, but we do want this to be a back and forth type of discussion. So please either put something in the chat or unmute yourself if you have questions. So we'll be monitoring that and paying attention as we go through. Another thing that you've probably noticed already is that this is being recorded, and the recording will be made available to everybody here on both the MHTPC website and the MapNet website. So hopefully some people are watching this through the recording as well. And then, as always, if you have any questions or comments for us after the meeting, please email newengland@mhtpcnetwork.com. And you can also see on their website the great array of events that they run as well. So next slide. Just a disclaimer. So all of this is public information that will be presented today. And this is from a partnership with SAMHSA. So excited to have that. Next slide. And another disclaimer, just to remind everybody that in all of the conversations and discussions, we like to take a positive, hopeful, strength-based approach to discussing all of the issues that come up. I know that's never an issue with this group, but great to present beforehand as well. So with that, I can introduce our speaker for today, Aruma Bello, who will be talking about cultural humility and the cultural formulation interview as it relates to first episode care. So Aruma Bello is a clinical psychologist and the co-director at the On Track New York program, and also an assistant professor of psychology and psychiatry at the Columbia University College of Physicians and Surgeons. So she received a PhD in clinical psychology from the University of Hawaii at Manoa and completed trainings at the Massachusetts General Hospital and at Harvard Medical School. So now she's joining us from New York. So Aruma, please, I'll hand it off to you.
Okay, great. Thank you so much. So it's my pleasure to be here today. As has already been said, I do encourage folks to chime in, interrupt, unmute yourselves. The more that we discuss these things, the more that we can find ways to actually make them applicable in our work. So I do have a whole slide set to present, but that being said, I do encourage discussion throughout. And because I am in the presentation mode, I really can't see the chat. So if people can let me know questions that are coming in, that would be awesome. Okay, so some of today's learning objectives. First, I wanted to give an overall understanding, an overall picture of how to deliver culturally competent care in first episode psychosis. And then have a little bit of a presentation or a discussion around primary themes that have been identified within the On Track network, primarily related to the intersection of culture and psychosis. And then we did develop a series of best practices. So I'll let you know the process that we used for developing those, and then some resources that we have available, publicly available on our website that folks can use in conjunction with the cultural formulation interview. So I think most people on here, just by virtue of being part of this MHTTC and MapNet, I think you guys are all aware, but I decided to just start from the beginning, right? So what do we mean when we say psychosis? And psychosis is a syndrome or a collection of symptoms, right? So it's not a diagnosis. In our programs, we're not necessarily working with people that have schizophrenia. There's a range of diagnostic categories, but the primary presenting problem that we're working on very frequently is what we term psychosis. And it's something that 5 to 10% of adults and 15 to 18% of children and adolescents experience, either auditory or visual hallucinations at some point. So this is sort of to normalize the idea that there's a cohort of people, right? We know the prevalence of schizophrenia is about 1% of the population. But that being said, there's a more ample or larger group of folks who experience psychotic-like symptoms. In the US, approximately 100,000 young people experience psychosis each year. As many as 3 in 100 people have an episode at some point in their life. The peak onset for a lot of these illnesses, or for the psychotic spectrum disorders, are between the ages of 15 to 25, right? So we're getting people when they're at their youngest, when they're just starting to identify what do they want to do with their life, what comes next, what are some of the ways in which they might want to kind of progress into adulthood, into the world. And at this point, then psychosis happens. And psychosis, as you guys know, can be quite debilitating, and it can be quite impactful in the way that it shifts somebody's developmental trajectory or life trajectory. So the beauty of what we have the privilege of doing through our coordinated specialty care programs or early treatment programs is to try to alter that course of disability, to try to help people early on so that they can get back on track towards a life that's meaningful, a life that's purposeful, a life that is full of potential. So when we think about, and I'm giving all of this as like a bigger context, right? So that then we can hone in on issues of culture, because we can't think of culture or the CFI to assess culture from the vantage point of, here's this person in front of me and what are they presenting with, or what is their culture, or what are they telling me? And the CFI will go into it, but it's an assessment tool to help you understand a person's perspective. But it's really important to understand all the other things that impact culture. And that a lot of that has to do with people's larger contextualization of where they live, where they work, where they play, where they interact. And a lot of it also has to do with how they are able or not able to access care. So when we think about a pathway to care, traditionally we know that young people who come to our programs, by the time we see them, have had less of an optimal pathway to care for the most part, right? So even before help seeking, even before they are actually going out and saying to someone, this is happening and I need help, there's already a lot of factors that contribute and delay help seeking. There's the idea of stigma, there's the idea of thinking that the psychosis is actually due to something else, or that people are self-reliant and they're going to figure it out by themselves before they ask for help, or that it's just teenage angst or stress or substance use, whatever it may be. But then even at the point of help seeking, right? Even at the point where they enter our system, the path is not linear to our types of programs. It's actually a very jagged path where people go through a lot of loops and a lot of sometimes traumatizing experiences, because it is very common, especially a couple years ago, even more so when there were less CSC programs around, for people to have lack of access. They can't afford certain care. They go to emergency rooms and it's like a revolving door. They go to inpatient units and then they get referred to mental health. Outpatient mental health systems, they don't engage because it's a traditional mental health model. They disengage, they go back to the hospital. Sometimes there is police involvement, and all of these sort of interactions in this pathway to care either lead to a long-term dependence of care. So it's the old view of how we used to think of schizophrenia, where it was almost like this sentence of disability, or an over-reliance in the mental health system, or dropping out of care. And none of those are desirable outcomes, right? Like, we want people to have a life beyond mental health care. We want to work with people to help them fulfill their goals, to help them fulfill the things that are really important to them. And the treatments that we provide and how we conceptualize and think about the care that we deliver to people is really based on the things that are important to them, not the things that are important to us, and are rather the mechanisms or the vehicles that people can use to get to the goals that they want to achieve. And what we've known from doing this type of evidence-based practice is that we can shift that trajectory pretty easily, especially early on. We have quite good success, right, in terms of connecting with people, in terms of keeping them engaged in our programs and improving at least short-term outcomes. So the science behind this, not to go into too many details, but things to keep in mind when working with people, and all of this connects to where they come from and their culture, is we know that for those people that it takes longer to get to care from the point that they have first symptoms of psychosis. So people with longer DUP, or duration of untreated psychosis, tend to do worse. We also know that coordinated specialty care type models or type treatments have been associated with better outcomes. So what we're trying to do, big picture, with the programs that we're delivering, with the treatments that we're delivering, and with sort of establishing CSC in a more robust way nationally, is to reduce the duration of untreated psychosis, because our programs are able to get people faster, have capacity to enroll more, but then actually also deliver evidence-based treatments and evidence-based sort of interventions that will actually carry people through towards better outcomes. So in that sense, what we have is a set of clinical services that I'm sure most of you are providing if you're part of a CSC model, and then core functions, right? So there's the services you deliver, like supported employment education, psychotherapy, whether it's individualized resiliency training, or CBTP, or whatever the psychotherapeutic approach is, support for families, pharmacotherapy, primary care coordination, etc. But then there are core processes. There's the way in which we do this work. It's insufficient to deliver the evidence-based practice without having a team-based approach, without having specialized training in how to work with young people with early psychosis, without doing outreach to the community to educate them so they can send you the right referrals, without focusing on various and creative and distinct ways of engaging with family and clients to help them stay enrolled in your programs and help them stay connected to your teams. Crisis intervention services are another piece of what we deliver. And all of it under the umbrella of shared decision making, right? So there's all these processes that underscore the delivery of coordinated specialty care. So in On Track, and I think in most CSC models out there, some of these core processes and underlying principles can be boiled down to a couple of categories, right? So there's recovery, the idea that, people have a potential for recovery, that recovery doesn't mean that symptoms go away necessarily, that everybody has an individual nonlinear journey, that we're there to walk with them with that journey, but that we as providers cannot predict people's potentials and where they might go. And that when we're seeing people in our programs, we're not, what's in front of us at that moment is not necessarily who the person is, but rather who the person is at this moment that they're experiencing psychosis. But rather this person has a whole life history behind them and a whole life history ahead of them that we need to consider when we're thinking about our work with our young people. And that leads us to individualized care. And we do this through the process of shared decision making, right? So the idea that we partner with people, we collaborate with people, we take into account their values, their preferences, into the treatment decisions that they're making, and they are the driver of the treatment, while the rest of us kind of rally and support and provide interventions to help support what their desires are and what their goals are. And then ideally that we're doing this all in a very culturally competent way, right? So what do we mean by cultural competence? And I'm going to talk about the frame of On Track and sort of a little bit of how we've shifted, or I would say developed or grown in this area across time. Because our model initially was very basic in terms of, we are going to deliver culturally competent care. That means that we understand that each individual and family that comes to us has an interpretive framework that they come with for how to think about symptoms, the signs of the behavior that is focused on, how information is transmitted, revised and recreated within families and societies. So it was a very individualized way of thinking about culture, right? This person in front of me, and my task as a provider is to kind of elicit from them what are the cultural themes or lenses that are permeating and the way that they and their family function, and how that may or may not explain what's happening or contribute to how they are engaging or not engaging in care. That was like the basic, right?
We have a question in the chat asking, how does shared decision-making work with substituted judgments in guardianship cases?
Can you repeat the question with what?
How does shared decision-making work with substituted judgments in guardianship cases? So in cases where the individual might not be making the decisions themselves.
So the way that we think of shared decision-making is that there's different layers. And for us, shared decision-making is a process. So we really follow Elwin's model of whenever there is a treatment decision to be made, and it might be a treatment decision that is like a broad, big treatment decision, like do I take meds or not? Or do I go to the hospital or not? Things like that. And at that point, yes, there are other voices, and sometimes it's guardianship, sometimes it's parents, sometimes it's, so to whatever extent possible, involving everyone in that shared decision-making process so that you are eliciting the different perspectives, understanding the different values, conveying the pros and cons and professional recommendations that you might have, and then having a process for deciding and weighing what is most important and how to move forward. But we don't think of shared decision-making as like this very linear endpoint where then you made that decision and it's done. Rather, that decision is just the next step. And if that worked well or it didn't work well, you bring it back and then you make a different decision as a group. When we're talking about issues of safety and risk, or where there are sort of parental or guardianship sort of rules that override, what you're trying to do is find some common ground and get everybody to at least understand each other's perspectives. There are some decisions that you cannot use shared decision making from, but we tend to think of those as few and far between. an example, and this doesn't speak to the guardianship so much, but I think it still illustrates the point, right? It's someone needs to go to the hospital. You're thinking as a provider that they are quite symptomatic and that they're at risk, but you don't want to like involuntarily hospitalize them. You want to try to put the cards out on the table, what's happening, what you're observing. And it might be that even when you're doing all of that, the person still doesn't want to go. And as a clinician, you're still going to have to hospitalize them, right? You're still going to have to do that step of maybe calling the police or doing whatever. There's still decisions under that big decision that the person could advocate for. So maybe it's which hospital to go to. Maybe it's what's the mechanism. Maybe it's not going by the police, but having somebody else take them. Maybe they don't agree to the hospitalization, but once they know they're going, they'll agree to other things so that their preferences and their needs are getting heard. So with custodial guardianship and things like that, it's a similar thing. It's like there's a higher level of this person has the power, but there's a lot of other decisions that fall under the big decision, where it becomes really important to have nuanced conversations and elicit the preferences and the values of our young people. And when you give people good information, they can make better informed decisions about what to do, or at least understand each other's perspective in a way that lets them compromise or try something. So it could be a decision that, for example, is time limited. We're going to decide to take meds, but we're just going to decide to do this for a month and then we're going to revisit this. It doesn't mean we're going to decide to take meds forever. So you sort of start having conversations in a different way to try to get everybody at least working collaboratively, or feel that they're empowered to share their opinions, that there isn't going to be this bulldozing of decision making that happens. I don't know if that answered the question, but if the person has a follow-up, happy to address it further.
Yeah, no, that's very helpful. Thank you.
So going back to the cultural competency piece, right? So when we were thinking of cultural competency in the beginning, we were thinking about it in this very like direct sort of, the person is in front of us and we have to think about how to assess their culture and how to integrate it into our conceptualization. And it was just like a very straightforward, almost too basic way of thinking about culture. And then we started working more closely with Roberto Luis Fernandez, who developed the CFI and his teams at Columbia, and started talking to our teams and grappling with our teams around what are the things that come up more often within FEP, what are the things that they're facing, what are the things that they should keep in mind, or that they're, and we developed this process for thinking about more guidance beyond just the CFI. So the first thing to think through, if we take a step back, and as I was saying, people come from societies. People don't come from like, this very austere thing and then they show up in front of you. They live in neighborhoods, they have societies, they have influences. We all do. So in order to think about cultural humility, cultural competence is not enough. Thinking more about cultural humility and incorporating the idea of culture to reduce mental health disparities, right? To reduce oppression, which is what we all kind of are trying to do by integrating culture. One of the first things to do is within your team, start thinking about what is your team's culture. How do you guys understand the treatment that you're delivering? How do you guys understand mental health? What are some of the sociocultural background factors that impact the lens through which you work with people and their families? What do you bring into this work that could impact your relationship with people? Because we all bring something. And in that something that we bring, sometimes it's really positive things and sometimes it's blind spots or biases that we need to kind of bring to the table and call each other out on it. So it's really looking at and building a culture of respect within the team and understanding where might the different team members within the team have strengths, or what are some discussion points that should be brought to light as you are thinking about the people that you're working with. Because culture definitely shapes the way that you interpret what your participants and families are telling you. It definitely shapes the way you understand their explanations of why things are happening. And sometimes when they're radically different from our clinical perspectives, there could be a clash. So the idea is that you want to understand what are some of your blind spots, what are some of your own biases, even before you're thinking about the person's culture, because that it is an interaction. It isn't like in a silo, and we are not blank slates that everything just comes to us and we're completely fair and neutral. So how do you do this? Here are some strategies when we think about how to do this. We encourage our teams to have discussions that engage in a process of self-reflection, but really eliciting discussions that help people explicitly state their perspectives. So not just like these broad-based discussions about, yes, it's this or it's that, but rather more in-depth discussion about what is your perspective based on your background? How do you think of these issues? And here we're not talking just about symptomatology and diagnosis, but somebody wants to pursue worker school, or they don't want to pursue worker school. How are you interpreting that? What are you bringing to the table related to that? What are your values around X, Y, or Z decisions in communities? What do you not know about certain communities? And then explore how your own culture, and it could be your personal culture, it could be your organizational culture, your professional culture, may shape these views. So I'm a psychologist, for sure. The way I was trained impacts the way that I think about the people that I work with, right? I was trained from a very like behavioral sort of perspective to think about formulations and conceptualizations and how things are linked together. And that impacts what I pay attention to or may not pay attention to versus somebody who has a more, psychodynamic leaning. So you bring stuff to the way that you're interpreting based on different layers. Then there's the agency culture, for example, and what is that instilling in you? And then identify and challenge stereotypes and biases. So if you're developing a trusting culture within your team, you're able to engage in these discussions and then sort of challenge each other. Like, hey, how come you're seeing it that way? What about this other thing? Did you consider this other way of viewing it? What else might be going on here? And then individual team members should really engage in a process, like an internal process to raise their own consciousness. So what do I think is happening to the person? What do I think is most troubling? Why do I think it's happening? What do I think are the causes? What do I think could be helpful or not helpful? So that you're starting to put at the table and at the forefront your biases, basically, right? So the idea is that if you're thinking it is psychosis and it's driven by a diathesis stress model, that's your explanation, which might be very different than a family's explanation of the person is possessed. How are you going to bridge that? Because you want to engage that family, you want to engage that young person, and you don't want to discount what they're bringing. But part of that is understanding, where are you coming from to this work? And then your work as a team, even before we're talking about working with participants and families, is to develop an awareness of the systemic issues that impact society and become literate on structural racism and its relationship to mental health. So this idea of cultural competence, where people come in and they teach us and they tell us and they kind of lay it out for us, is only half of the equation. We do want to understand people's perspectives around their culture, but it is our responsibility to develop an understanding of systemic racism. It is our responsibility to develop an understanding of how different pieces in our society disadvantage different groups of people disproportionately. And how does that play into what we're seeing in front of us? So on a very basic level, right, we know that race is not a biological construct. There isn't like this gene that tells you what race people are. It's a social construct. And politics and power and information is what kind of guides this idea where people might think that race is like definitive, when in reality, you could have somebody in front of you that identifies as something, but when you look at their sort of background, there's just a lot of different influences and a lot of different things that are actually contributing. And then being really familiar around structural racism as an anti-oppressive lens, right? So the idea that structural racism, in a nutshell, right, in a definition that's sort of a nutshell, is the normalization and legitimization of historical, cultural, institutional, and interpersonal dynamics that routinely advantage whites while producing cumulative and chronic adverse outcomes for people of color. So it's at the system level. We're not talking about it interpersonal discrimination. We're talking about there are systems set up in our society that advantage some groups over others. And there's laws that are passed, across history and across time that advantage certain groups over others. And all of that impacts people's lives. All of that impacts people's potential, what people can do in their worlds, the types of lives and resources, and who they sort of interact with, and the communities in which they live. And it is our job to understand this so that when we're working with someone and they're bringing things up, we're not naive around the bigger societal factors that are impacting this clinical picture, but rather that we have a working understanding of the bigger things at play that, might have led this person to you. So that's where we go into like social determinants of mental health disorders, right? So this is the idea, and there's research to suggest that social and economic conditions that directly influence the prevalence and severity of mental disorders. So adverse social and economic circumstances, right? Including poverty, violence, inequality, marginalization, forced migration. All of these things increase the prevalence of mental health disorders in minority groups or people of color. And the increases can be a consequence of experience of discrimination and exclusion, genetic background, differential and cultural interpretations of symptoms, or a combination. So there isn't just one thing, it's a combination of things. And here's one model that sort of tries to contextualize it, right? So you have the individuals here in this big circle on the bottom, and then you have what we call proximal factors, right? There's the person's age that impacts their ethnicity, their gender, their income, their debt, their assets, the safety and security of their neighborhoods, the environment. So is there trauma? Is there distress? Is there intergenerational trauma? And then social and cultural factors, right? So individual social capital, social participation, social supports, education. And then there's like another layer of more distal factors, other things that also contribute, even if it's not, you can't pinpoint it directly because it's at the systems level, right? So it's community diversity or population density or economic recessions or economic inequality, infrastructure in the neighborhood. What are the things that they have available to them? What are the resources in the neighborhood? Is it a poor neighborhood that's full of violence, or is it a more resource neighborhood where there's food and parks and grocery stores and libraries and other things that people need in order to have a more thriving sort of experience in their environment. The experience of natural disasters or war or conflict or climate change or forced migration or community and social capital, social stability, or just cultural stability, right? All of these things interplay into a person's life. And then psychosis is one piece of this, right? The mental health is one piece, but all of these things impact mental health because for all of us, they do. Even if we think of ourselves, right? Where we come from, the life that we had, and the adversities, the limits, the under-resources part of our life, coupled with the resources that we had, the supports, is kind of what allowed us to get to where we are. Either because we overcame a ton of stuff, or because we had pathways to achieve certain things. And it wasn't up to us. It wasn't like a decision that I made to go do X, Y, and Z. It was something that was allowed by society, by larger infrastructure that can limit or allow. So when we're seeing someone in front of us, in addition to what they're sharing about their cultural experience and their cultural perspective, it is important for us to understand what is the community that they come from? What are some factors that serve as oppressive factors? And what are some factors that actually facilitate growth and facilitate resiliency? And how is that interplaying into the presentation and the person that you're seeing and their family? So neighborhood level, and this is some research that has come out, neighborhood level socioeconomic deprivation, for example, is strongly associated with increased prevalence of psychotic disorders, also depression and common mental health in young people. So exposure to violence, underemployment, under-resourced facilities, all of that has been associated with increased psychosis. Living in an urban environment has been reported to be an increased risk of developing schizophrenia. Racial segregation and community instability are associated with depression and psychotic disorders. A high density of a particular ethnic group, it could have benefits. It could be protective in some ways for individuals of that same ethnicity. So it might reduce psychosis, it might reduce depression, even if they are from a minority group. And that's mediated by the increase of social support, a sense of identity, and positive self-evaluation. So once again, this shows the complexity. It's not just everybody who comes from a poor neighborhood or everybody who is Black or everybody who, but it's rather the intersection of country, community, experience, and the different factors that impact what the person is able to do or not able to do and how they identify and the supports that they can garner. So when we think of cultural humility as a framework for doing some of this work, we're really thinking about the ability to maintain an interpersonal stance that is other-oriented. And what do we mean by that? That it's not what do I think, what is important to me, what are my values, but rather I'm oriented to the person I'm working with, what is important to them, what is their identity, and what are they identifying? That's what's important. And it's different from cultural competency, which is kind of like teach me and tell me. Cultural humility requires that providers be aware of the sense and are sensitive to historic realities, like legacies of violence and oppression with certain groups of people might have experienced. And therefore, whiteness stops being the norm where we compare everything to, but rather we are comparing people to themselves. Because the way that our system is structured in mental health and our research and everything, it has prioritized, when you look at studies, when you look at participants in research, a lot of it comes from more white population. So that becomes our reference point. And we want to shift our reference point. Instead of trying to think this versus that, the reference point should be what the person is bringing to you and what you know about their neighborhood, their community, their history, their whatever it is, their ethnicity. And then the culture formulation interview, once you have that stance and you've done that work as a team and you are understanding of your biases and your understanding of sort of the structural barriers that people are facing in the communities that you're serving, then this cultural formulation interview becomes a very useful tool to help clinicians understand what that person is experiencing and how they view it. But doing the cultural formulation interview alone without understanding all these other factors is not enough. It doesn't give you the full picture of all the things that might be impacting some of the decisions that this person and this family in front of you are making, or to really understand how to engage with them or what is important to them. So when we think of cultural humility, structural competence, right? The idea that we understand very instrumental systems that are impacting people's ability to access care or limiting people's ability to access care. And then we think of using the CFI to then understand that individual's sort of vantage point. Then you have a clear picture and a clear framework from where to start. So now getting into the CFI, right? The CFI is, it's part of the DSM. It's a way to think about and contextualize, like I said, the person's perspective and their vantage point, not only about what they're experiencing, but also about how they think about care, how they think about working with providers, how they think about what's worked and what doesn't, and what are they bringing to the table. So it's this opportunity to very directly assess these things rather than making assumptions or letting them come out sporadically throughout the course of treatment. So the way that it was initially proposed, or the way that it's been proposed to be used, is some people use it as part of that initial intake. So some of the CFI questions, because it is a detailed, open-ended sort of assessment, on a practical way, if you can integrate it as part of your biopsychosocial or as part of that intake questionnaire, then it does line up with some of those things that you need to ask anyway for an intake. Doing it in that way also puts it at the forefront of treatment. So you're leading with, hey, not the biomedical model of what we think of psychosis, and let me ask you all the symptoms to see what diagnosis you have. You're leading with, I want to understand what you're experiencing from your vantage point. I want to understand how you describe this and how you relate to this. So that is a really important point because it improves engagement. For young people, particularly with FEP, who might be averse to engaging in treatment to begin with, who might think they know better, or who might have this idea of like, I know what you're going to do. You're going to lay me down on a couch or give me meds, and I don't want to do any of that. Starting with, what are you experiencing and how do you see what's happening? And how can I understand this from your point of view? Really helps with getting on the same page and building some of that engagement and rapport. So a lot of team members use the CFI very, very early on as a tool for increasing engagement. There are several versions of the CFI. There's the client version that has 16 items. There's also an informant version that you could use with participants and families. And then there's adjunctive modules. And if you go, there's like a whole website that you can go to, and it shows you those other modules. For at a minimum, what we ask our on-track New York teams is to really use the client version. So what does it include? I'm gonna tell you the domains. I'm not gonna go through every question because once you know the way they thought about it and the way that they thought of the domains, I think that the actual administration of it is pretty, I mean, you just ask the questions and have an open-ended discussion about these things. But the idea is that you want to hit all of these domains, right? So the first domain, you want to understand from the person's perspective, what is their cultural definition of the problem? That's very different from, are you hearing voices and how often and how intense are they and how do they impact your functioning? But rather, what do you think is happening? Why are you in the hospital if you're seeing someone in the hospital? Why do you think your parent brought you here? What's bothering you? So it's really eliciting from them what the quote unquote problem is. And the problem might be, my mom wants me here. I don't want to be here, but my mom is the one that wants me here. But you use that language for the rest of the CFI, and you use that language to explore. So why does your mom want you here? Oh, because I've been getting bad grades. So why are you getting bad grades? And what do you think is causing that? And that unravels the psychosis. Eventually you get to the psychosis. It's not like we're saying you don't need to understand the symptomatology or comorbidities or any of that. But the idea is that the way you're getting at it is in a different way. And you're from the get-go contextualizing it with how the person thinks about it and getting that understanding really early on. And then whatever language they use to describe the problem in the first domain, you carry through that language across the domains. So for the second domain, you really focus on cultural perceptions of cause, context, and support. So you start asking questions about, what do you think caused this? What are the factors that are contributing to it? How do you understand this? Well, what does your culture say about this? What does your community say about this? How do you identify? Because culture could be anything. It could be race, it could be ethnicity, it could be all kinds of stuff. And then what is the role of your supports? Who are your supports and what is their role? Do they agree with you? Do they disagree with you? Do they think something else is happening? And how does the person understand that? And I'll give you an example. In one of our teams, there was a participant who was having a lot of I think it was like positive symptoms, but also just symptoms getting in the way of like some thought blocking or an inability to sort of put thoughts together. And they used to hang out with a group of kids, a group of young people who were like rappers. That's what they used to do, used to rap. And part of what they were trying to understand were his goals around social connection and decreasing social isolation, increasing social involvement. And one of the things that really came up early on is that the main thing that this young person identified was with this rap culture. This was a huge part of his identity and a huge part of how he understood his talents and strengths. And part of the reason he didn't want to go back there is because he was well known in this group as being one of the best rappers. And if he couldn't perform in the way that he used to perform, it would be quite shaming. And to him, this was more important than any other cultural component. So if the clinician wouldn't have taken the time to understand the intersection of how this person identifies and the things that are important to him in terms of the groups of people, they could have totally missed that. Because plenty of times we tell our young people, hey, go and hang out with your friends, go meet up, go do this, let's practice talking, let's do some social skills training on how to start conversations or harm reduction. So, but very rarely do we sit there and say, oh, wait, you are going to be in a group of people who have this expectation that you have this skill, and all of a sudden you've lost the skill. And how are you actually going to navigate that? And maybe that isn't the best group of people to hang out with right now. Another example was this young man who didn't want to take medicine, very much believed in so more like holistic medicines and new age sort of treatments. And the team at some point couldn't really figure out his explanation for things. How much was it just that the team wasn't aware of these types of explanations, or whether this was more delusional? And what that clinician actually did with that participant, he said that he was teaching I think it was a yoga class or something in this like local community center. The team went with him, and they would go with him, like whether it was a clinician or another team member, and they would go with him several times. And there they like learned, hey, wait a minute, this is actually a whole community that thinks in this way. This is not idiosyncratic. This is actually a cultural explanation to how to address problems. How can we partner? What's some common ground here around what we're recommending versus what this cultural framework for understanding how to deal with what this young man is experiencing? And once they understood that frame, they were much better able to find common ground and find strategies that would be more amenable to the young person, while also respecting that this was his primary source of support and the community that he really related to. The other one is cultural factors affecting coping and help seeking. From the beginning, when people come to us, we have to assume, even before they've been in care, that they have coping strategies. We all have coping strategies. Some of them are positive and some of them are negative, and there could be at times better ones. But you want to elicit from people what do they do to cope with whatever the problem is, rather than assuming that you're going to teach them coping strategies, because that gives you an understanding of how they think about things and how they think about navigating the world. You also want to understand past help-seeking behaviors and barriers to help-seeking. And this gets at the structural pieces of things. So is it transportation? Is it financial? Is it lack of insurance? Is it language? Is it, I don't know, that your family thinks mental health systems are out to get you and are horrible and, not the way to deal with problems because they're highly stigmatizing? What has been the framework for past help-seeking? And what were some of the things that already came up? And it's pretty evident, right? That helps you troubleshoot, and it helps you sort of be proactive about conveying messages and meeting people in ways that they find relatable and that they find acceptable, rather than assuming that they're going to be fine with whatever you can offer. And then you want to understand the factors that are affecting current help seeking, right? So what are their current treatment preferences? What are their current expectations? What are the current barriers to treatment, so that you can address those head on? And it might mean that they want you as an expert to tell them what to do, or it might mean that they want to tell you how to proceed, or it might mean a combination, or they might have an expectation about therapy that is actually a misconception, or about meds. A lot of them don't even understand that we work from a framework of shared decision making, or from a framework of really valuing people's preferences. They're used to more paternalistic models that tell them what to do. So sometimes it gives you an opportunity to re-educate how in coordinated specialty care, we can provide a different set of frameworks for working with people, a different set of flexible paradigms that they might actually think is more respectful and might want to engage with. So I'll pause there for the CFI before I go into this guide. Any questions on the CFI? Let me see if I can. And please unmute yourself if you
So we actually have disabled the feature that you're able to unmute yourself, but if you'd like, you can always raise your hand. It's down in the reactions button, and we can unmute you just so that we can avoid everybody unmuting at the same time.
Yep. No worries. So if you can write in the chat if you have questions about the CFI. I see somebody's raising his hand.
Hello, can you hear me?
Yeah.
Hi, I'm Ibrahim. I'm a certified peer specialist here in the state of Georgia. We've had a client that do his spiritual belief, right? He he wants to take herbs and like you mentioned earlier, and
Mm-hmm.
then we was talking to him. We was saying, well, herbs may be a great thing, they may work, but what we're offering here has been clinically proven to be effective, and demonstrated.
Mm-hmm.
And so in getting the individual to try to understand his culture background and try to talk to him about possibly trying some medication. The medication was working for him,
Yeah.
and someone sold him on this herb.
Yeah.
And so just in that, and what you're saying about the competency and the factors and the domains, so how can we approach this individual to get them to try to give us a try for an extended period of time before they move on to something else when they was getting positive results?
Yeah, I mean, I think it's more of kind of how we've been talking about it, right? So if a person has been taking medications and they decided that they want to stop taking medications because they want to try something different, even though from the team's perspective they were having positive reactions, what do they think about it? Even though the team is observing positive results, did the person think that they were getting positive results? Did the person think that there was something negative or an underside of this that maybe they're not expressing, but is actually more important? So it's, yes, my voices go away, but I'm gaining a ton of weight. Or yes, my voices go away, but in my culture, this is toxic for these Western medications are toxic for the system. So you want to be able to allow space for the person to fully elicit how, in this scenario, how they think about medications, and give them space without judgment to kind of share all the ideas that they have about the medication and what is it about something that you perceived was working for them. Wasn't the benefit they were getting obviously wasn't enough to stay on it. And then from there, then what are the herbs? And as you said, one thing is to give people good information, right? And it could be like the clinical or research information around medications and rates at which they work and what we know and blah, blah, blah. And that's part of it for sure. But the other part of it is like, how does that factor into their decision making? What are some of the other things that are contributing? So for example, what was so valuable about this other person recommending the herbs? Who is this person recommending them? Is it somebody important in their lives? Is it somebody that they trust? Is it somebody that they believe in? Is it somebody that is part of their bigger social support network? How does that relationship compare to the relationship with your clinician, with your team? And then if possible, is there a way to partner? Is there a way to partner with that other person who's recommending the herbs? It's very different if the person is saying, well, I read something online and I went to a local GNC and I bought 3 different medications, like, I don't know, nutritional supplements, versus there's this person that's telling me, or, this comes up sometimes with traditional medicines, right? For indigenous people, for the Chinese traditional medical doctors. Can you partner? Our teams have done that. Can we find some common ground? Let us understand what the herbs are about. What are they about? And then if they don't want to take meds, can we set some benchmarks? Okay, do you want to take this for 3 months, a month, 2 weeks, whatever seems reasonable? And then we revisit if it worked or not. What is our plan? So sort of thinking all or nothing, either they give us a chance or they don't give us a chance. Maybe it's they'll give us a chance after they tried this, after they see that we're super open and supportive of their decisions and we're holding their hand along the way so that they're staying safe. And if things change, the minute they change, then they might give us a chance. So I would just say, like, try to take a curious stance around how the person or what value the person has in this other treatment modality. So that, and that's going to give you clues around how to bring up conversations, because the meds in and of themselves, nobody wants to take meds. But if you want to go to school or you want to go to work or you want to achieve something and your psychosis is getting in the way, then you could try the herbs. And if the herbs don't work for a couple of weeks and you're failing your classes, like maybe at that point you're willing to try something different, like the meds. Or you can compare. Remember when it was meds, you were like this. Can we track stuff? So you use the therapeutic sort of skills to set up conversations, tracking of how things are going to help the person understand one experience versus another. Does that kind of help? Any follow-up to that?
Yes, thank you.
And then we have another question in the chat about how does the cultural formulation interview align with the SIPs? So for this clinical high risk group rather than a psychosis group, and how have you or how would you incorporate those two tools together?
I mean, that's a super interesting question. I mean, the SIPs is such an assessment tool to understand if people are, clinical high risk, for psychosis, and try to disentangle that very messy clinical picture. But I do think, and definitely the SIPs has some ways of asking these things in an open-ended way to try to understand if it is like a cultural sort of driver. I would say the way I would think about it, and this is not necessarily just like off the cuff, but if I'm thinking about working with someone, the SIPs is something I'm going to do at the front end, probably to get diagnostic clarity or determine diagnostic criteria, maybe even eligibility. The CFI, I'm using it when I'm working with someone, like this is my client. And now I'm developing a frame of how to work with them, how to understand them, how to think about the care. That being said, if you're feeling like some of the SIPs questions are falling short, you could integrate some of these very open-ended CFI questions to have people elaborate further. But the SIPs is like very like straight to the point in terms of diagnosing, I would say. So I don't see them, because the point of CFI is not to diagnose. You're not getting at any diagnostic thing there. You're getting to understand how the person understands what they're going through, which is kind of, so in our teams, we don't do the SIPs, but we do like a timeline follow back assessment to determine eligibility. And that very much asks people like, when did you start hearing voices and how long and this and that? And how do you understand your problem? But after we do that and we accept people into the program, then we do the CFI during like the intake, the understanding of how to work with this person. Because for us, the intake is not eligibility. The intake is once you've already admitted someone. So depending on your program and how you've broken up these different front end pieces, one could be more assessment to determine diagnosis or to determine eligibility, but the other one is really to develop a working alliance and an understanding. Okay, so the second question, I have a chat open now. How would you tailor the CFI for individuals who may not have good insight or lack insight into their problem? Once again, there, you're assuming that you know what the problem is. If what you're trying to say is the person doesn't have insight into their psychosis, that doesn't matter. You want to understand what they think is the problem. And that's why I use that example of my problem is my mom wants me here. My problem is not the voices. You want to understand their perspective and not bring in your understanding of what's going on for them. You want to keep it super open, and all the information you gather there will inform. I'm not saying throw your judgment out the window and let's pretend this is not psychosis, but it gives you an understanding of how they are viewing what's happening to them. And even if it's not, they're not saying voices or delusions or anything, they will hand it to you by answering these questions in terms of what is important to them. And that's the stuff that at the end of the day, we need to pay attention to in treatment. Secondly, that might be an instance where you use the informant version and you ask the family or you ask the support network, what do they think is going on for the young person, and ask some of these CFI questions to get more of a rounded picture. If the issue is not so much insight, but let's say that the person is just not sharing a lot. and not really answering your questions and not elaborating on this stuff, and you feel like, I really don't know who this person is based on these questions, then you might bring in collaterals and ask some of those. What happens when their worldview spontaneously involves you as the interviewer? For example, psychosis involving past lives or other delusions of relationship with the interviewer. So there, I think we're going into a different territory. This is not culture. This is psychosis. So there you would use a similar CBT-based strategies. You might use some cognitive restructuring. You might use some behavioral experience. You might use some distress tolerance. You might use whatever CBT or whatever modality you guys are delivering to actually work on the symptoms of psychosis. That's how you would kind of address that piece of it very much, because it's very much a delusional interpretation, right? And many times we work with people who integrate us into their delusions. If it's a cultural view, not a delusional view of, I as a person believe in past lives and I believe in reincarnation, which is very much a belief that many cultures hold. And I believe that we had a connection in a past life because I think we all reincarnate together. Then your best bet is to get educated on that and understand, what does that have to do with anything? Does it impact? Does it not? How does the idea of, and it might be, okay, let's take it to another level. Let's say it's not the person, let's say it's the family that has this view. So it doesn't fall into that psychosis realm where it's a delusional content. And the family thinks you were sent to us because we all, reincarnated together into this current life. And, we really have all of our hopes in you. You explore that. What does that mean to you? What does it mean that you're providing? Does it have a relevance? Does it not have a relevance? How do you respect that cultural belief? How do you work with it? In what way does it interfere with a therapeutic relationship, or it doesn't? Same way you would deal with anything else cultural that arises that impacts treatment or doesn't impact treatment, and you navigate it in that way. But that would be different than a delusion around the relationship with the provider.
And one question that I have kind of more on the procedural end, something that, struck me as you were talking is this fact that, everybody comes into treatment or into a program with a culture, whether that's their friend group, they're like a teenager, the things that they're seeing in their community. So are you guys doing this cultural formulation interview with every person who comes into the clinic? Because, historically, I've heard it brought up in the case of, oh, this is a culture that I'm unfamiliar with. But in reality, it sounds like you're not completely familiar with any individual person's culture.
And that's exactly right. And that's where the cultural humility comes in, right? And cultural competency comes in. It's the marrying of what do I know? But then I want you to help me understand your point of view and where you come from. So in our model, when you do the on track model, everybody gets a CFI and we have a core session. Like our model, for those of you that are familiar, like we don't have a manualized approach to the therapeutic intervention. It's very CBT based, but it's sort of you pick and choose what you're doing based on the presenting problem. And yet everybody goes through a core session on culture. So there is an expectation that the clinicians have a discussion about culture with every participant and family. And that has to happen at the beginning of treatment, and it has to kind of be foundational to any of the work moving forward. So yeah, and that's why they say to use this as part of the intake, because you do an intake on everyone and you get background on everyone. So if you could expand some of that background that you're getting by using the questions of the CFI, you're getting a richer history and a richer contextualization to then help you determine your treatment targets and how you're understanding what's going on for this person. Okay, so in our group, as I mentioned, we started with the CFI, and then the CFI wasn't enough. Our providers were still struggling with specific themes that were coming up for FEP, and they always had more guidance they always wanted more guidance and more questions when we were delivering the technical assistance. So we partnered with Roberto Luis Fernandez and his group, and we went through this process where we asked I remember this was a while ago. We asked certain program, like the providers, to be part of this process. Us as the training and technical assistance team were also part of the process. And then the experts, so like Roberto and his team as like the researchers, the experts in cultural competency. And together we developed this guide that really addresses some of the most common themes that we found our clinicians grapple with. So the guide defines culture. It provides a framework for understanding symptoms of psychosis and culture to inform treatment. It includes case examples to illustrate how culture shapes participants' experiences, and it outlines some key principles or best practices. And this is available on our website. So the themes that our clinicians identified at the time as primary that kept coming up and up with a lot of people were issues around religion and spirituality and how to navigate that. Issues on the family culture, like when your family thinks one way and the participant thinks in a different way. Issues related to language barriers, issues related to gender and sexuality, and issues related to youth culture. Those were the biggest sort of themes. And then under each theme, there were sub-themes. So for religion and spirituality, a lot of what came up is the individual's family or religious views conflicts with that of the team. The team thinks about psychosis one way, the family thinks about psychosis another way. The team thinks it's a mental illness, the family thinks it's you need prayer groups and it's, you know, a possession. I don't know. And then we provided some like strategies, and they're very basic, of what to pay attention to and try to do if that's what's coming up. The other theme was religion and spirituality serves as a major source of support and a framework. So this is the opposite. This is not that it's clashing, but rather they're the major source of support. So how do you partner? How do you understand the role of religion so that you can actually leverage that to help build resiliency? When the provider's religious views interfere with the treatment, right? When our views are like, there's no way I think about this in this way. And then how do you work with someone that has such a divergent view from yours? And then religious beliefs contribute to increased psychotic experience. So the idea that there's one example in this video that we created, that the young person feels that the voices connect them to God and connect them to sort of the religious realm. And this is something that they highly value. And they feel that when they take medications, the medications get in the way because they take away those voices. So they lose their connection to God, which to them is like a driving force in their life. So how do you kind of work with that? And how do you navigate that? And then obviously there's like different recommendations. So here's an example, right? A 22-year-old Haitian immigrant who's devoutly Christian and believes he's being possessed by a demon rather than symptoms of psychosis. Originally, he agreed to take meds, which help reduce his symptoms, but upon discharge, he was advised by the family to stop taking medications and pray. The team has tried various strategies for providing psychoeducation, but the family is adamant that the only thing they believe will stop is continued prayer in hopes that the symptoms improve. The family refuses to speak with the team about treatment or their objections to medications. However, they mention that they don't believe the participant is old enough to take medication. The individual participates in talk therapy. He takes liquid vitamins. He feels that the meds slow him down, and this causes the demon to slow down too. So he worries that because of this, the demon won't be able to escape his body when the religious helpers are praying over him. So these are real scenarios, like conglomeration of scenarios that our teams like brought up. So here, understanding everyone's multiple perspectives, right? The participant, the family, the other religious experts, inviting multiple perspectives rather than making people feel like they can't talk about this stuff because you don't agree with it. And I apologize for my dogs. Providing information, developing an awareness, and then really understanding what's normal for that person. What does that person think is normative? It is normative in this culture to go and have people pray over you to take out a demon. So how then do you incorporate that? Because that's not all of a sudden a bizarre belief. That's actually part of how they function in their life. The other one that came up was family culture. And some of the sub-themes, so intergenerational acculturation, differences in that affect the views about FEP and their treatment, the impact of culture-related family dynamics on illness or treatment, the effects of culture on views of the participants' functioning. So once again, I'm gonna give you an example. So George is a 19-year-old US-born Indonesian man whose immigrant parents want to be involved in every aspect of his care. He feels uncomfortable including them to this extent, stating that some things are my business, especially the substance abuse related aspects of care that address the marijuana use associated with his initial psychotic episode. George feels that his parents would never understand his substance use or his desire to not pursue the family retail business. His parents, by contrast, argue that it's typical for parents to have a strong voice in making treatment decisions in the case of adolescents such as George. So what are some of the strategies? There's a disconnect between the participant's perspective regarding level of family involvement and the family's perspective. And that is problematic because in our teams, right, we advocate family involvement. We know that people who have their families involved in their care tend to do better. At the same time, treatment is based on the individual preferences. And in this case, there's some cultural divides around like a older generation and how they think of parental involvement and a younger generation and how they think of parental involvement in a more Americanized sort of setting. So the treatment team facilitates a process for finding common ground. Instead of saying, hey, George, we totally align with you because we're from this country and we get what you're saying, how do you value and bring voice to the family's perspective, knowing that they really care about their son and they care about what's happening with their son. And this comes from a place of caring and a place of concern and wanting to help. And then how do you find some common ground? What are some things that George can live with? What are some things that the family can live with? And then you take the time to understand everyone's cultural identity, not just George's, and how they interface. And you create opportunities for discussion with the team meeting. So you're discussing it as a team of how you're relating to George and how you're relating to the family and what are some of the ways that this stuff is coming up and how to navigate it. But then also by facilitating meetings with George and his family, right? So this notion that maybe it's easier for them to have some of these really hard discussions in a session with you, instead of letting them kind of deal with it at home or ignoring that these dynamics are happening. The other one is language. And I think in a lot of the places that we work, language is an issue, right? So the idea is that providers identified struggles with working with interpreters, right? Because we all say, okay, you just work with an interpreter, you have to kind of provide services no matter what. But when you have very specific mental health treatments, if the interpreter is not proficient in the language or the understanding of what you're working on, it could be quite difficult to translate. Another theme that came up was when treatment is providing using interpreters, but not other services due to the language barrier, right? So for example, you use an interpreter for therapy or for the psychiatrist, but do you use an interpreter for the peer work? Do you use an interpreter for supported employment education? How are you able to deliver all the services, not just the clinical services? And then when the quality of the interpretation is suboptimal, and how do you determine that? So here, an example that came up is Jose is a 17-year-old male immigrant from Central America with a recent initial hospitalization, and he presents to outpatient care with psychotic and somatic symptoms. His English is very limited. He has an 8th grade education from his country of origin, and his family is not involved in his care. While the primary clinician speaks some Spanish, individual treatment relies on telephone interpreter services. However, access to other services such as supported employment and education or group therapy is limited due to a systematic lack of Spanish language capacity. The young man wants to work and send money back home. So some suggestions are using interpreters across all services and advocating within your agencies to provide interpreter services, not only to like the clinicians, sharing information using tools and materials that are available and developing language that is specific, for example, to group therapy, or developing like family groups in Spanish or individual groups in Spanish, or if you have enough participants. So thinking outside the box when it comes to creating treatment groups. Around gender and sexuality, the sub-themes are when cultural constructs of gender and expression of gender identity emerge in care, and when cultural constructs of sexual expression and sexual orientation emerge. So let's go to an example, and I'm being mindful of the time. Rafi is a 23-year-old Bangladeshi American who is being pressured by his parents to marry and have children because it's his duty to his family. The family identified several potential brides for him during his hospitalization, but he doesn't want to meet them. At this point, Rafi is focused on improving from his FEP symptoms before embarking on he feels will be a life-changing step. So learning about the cultural expectations, rules, and gender norms, not just from Rafi, but taking the time to discuss this with the family, understand the culture, understand what this means, and stay away from the idea of that's just how they do it, and rather, what is the function? In some cultures and in some societies, marriage is what allows you to stay in a support group that provides emotional support, financial support, and all kinds of stuff within your community. And not going through these steps could actually alienate the whole family from these cultural groups, which we know are helpful when somebody is undergoing difficulties, because they help with not only social support, but like positive self-evaluation. So really getting a deeper, more nuanced understanding of how these things work and why they're there and why are there these norms, rather than, oh, it's this culture that just believes in marrying people. And, you know, this is problematic because in our view, he shouldn't get married. Getting a better understanding of what are the functional components of this, why does the family want it, why is it important to the family, and then exploring rooms for compromise. Exploring rooms for personal feelings or biases from each of the perspectives that are involved. And then finally, youth culture. And we talked a little bit about this in like the rap example that I gave, right? We're working with young people and they have a culture onto themselves and they have a way of viewing the world onto themselves. And sometimes like we're not as familiar. Let's be honest, a lot of us, there's an age gap, a huge age gap between the people we're serving and us. So the impetus is on us to develop an awareness of different cultural pieces that are normative for youth, whether it's internet, whether it's gaming, whether it's social media, whether it's the use of smartphones, and then trying as much as possible to integrate this into the treatment. So for our teams, we realized that a lot of participants were playing the same video game without realizing it, though they were doing it with other friends. So we provided a group therapy discussion on how the game helps reduce negative symptoms. So it's really getting from people, what are they doing? And when we think that might be isolation, maybe not. Maybe this is the new way to socially connect. And then finding strategies to incorporate youth culture into the way that you're thinking about engaging with people and the treatment that you're delivering. We have, I'm just going to show you some resources in these last couple of minutes. There is a video project that we did in collaboration, I think it was with SAMHSA, where we did 3 training videos that get at this, these themes of culture, and they're a companion guide to the guide that I showed you earlier. And it's called Windows of Opportunity in Early Psychosis Care, a companion guide for navigating cultural dilemmas. So it's a companion guide and the videos, and you can look at them, and it helps you kind of think through how to incorporate some of these strategies or how to think about some of these cultural dilemmas and how to navigate them with the folks you're working with. And these are the videos. So there's navigating religion and spirituality, family relationships, and masculinity and gender constructs. And then there's the resources at the Center of Excellence for Cultural Competence, and that's Roberto's shop. And then there's resources on our website, like the guide is on our website, but the CFI and some training content on the CFI is also, I think, available in the Center for Excellence of Cultural Competence. I think that's it for my presentation. Do folks have any other questions? I don't know how much time, or maybe 10 more minutes, but I know you guys have some final announcements to make. So any other questions or things to clarify?
Just to respond to Tori's question in the chat, if we can share these links in the chat, if you are able to do that, please do. But we can also definitely put them up on the webpage afterwards, so you can look at it through that way too. And I believe, Vanessa, correct me if I'm wrong, but people will be getting an email with links following as well.
Sure. And then Susan, I think there was a question. Susan Gingrich had posed a question about the videos, and yes, that video is that one that I showed here, and you can, there's the link. I think it's this one, the windows of opportunity in early psychosis care, navigating cultural dilemmas about religion and spirituality, and it sort of showcases how they help this young woman kind of navigate her religious and cultural beliefs with the way that the team sort of thinks about them and the types of open-ended discussions that they had. And then the guide, I think, elaborates further. Any other questions, feedback, thoughts? I don't know. Okay. So hand it back to you guys. I will go to the next slide.
Perfect. Thank you so much. That was, yeah, I see some people in the chat, but it's very informative, awesome presentation. So really appreciate it. Only closing announcements are that we have a couple other upcoming events, which you can see on the MHTPC's website. I know they've done a past series on specific cultural issues, so those might also be particularly relevant to this talk as well. But yeah, thank you everybody for coming. Thank you, Irma, for presenting to us, and have a great weekend. Oh, wait, we have one raised hand here.
Can you put the website where these events are listed in the chat? Thank you.
Sure, yes. There it is. All right, thank you everyone, and have a good weekend.
Thank you. Thank you for the opportunity. Take care.